to Dr. Alan Bell, who will talk about the patient with newly diagnosed COVID-19 presenting to a family physician office, but does not require ER visit. Alan.
Thanks very much, Jim. These are my disclosure. As Jim points out, I am a primary care physician dealing with patients in the trenches. Next slide, please. Why don't we get right into it and talk about Charlie? He's a patient who presented to my office. He's a 67-year-old auto mechanic complaining of fever, productive cough, headache, and myalgia of 3 days duration. He was not having any red flag symptoms, no shortness of breath, chest pain, or gastrointestinal symptoms. Charlie lives with his wife and an adult daughter. All are fully vaccinated, defined as 2 shots. In addition, they have all also had a booster dose of COVID-19 vaccine. He had a PCR positive 1 day prior to his presentation. He's got a few significant comorbidities. He's hypertensive, he's hyperlipidemic, he's obese, and he's got a 20-pack year smoking history under his belt. His current medications are perindopril and indapamide and rosuvastatin. Next slide, please. So what are the considerations that have to go through a primary care physician's mind when a patient presents with a clear story of COVID-19, perhaps hopefully mild illness? Well, first of all, we're going to have to consider isolation strategy, and not just for the patient, but also for the patient's family and any household, his household contacts, as well as any casual asymptomatic contacts. We have to consider whether or not he may require further investigations. How are we going to monitor him? When should he be referred to hospital? And what sort of follow-up care does he need? We have to consider treatment options, both in the anti-inflammatory realm, whether it's inhaled oral steroids, fluvoxamine, colchicine, tocilizumab, as well as specific antiviral therapies. And we have 2 currently available, remdesivir, as well as nirmatrelvir, ritonavir, known as Paxlovid, and perhaps another one on the horizon known as molnupiravir or Lagivrio. And also we have SARS-CoV neutralizing antibody. The one that remains is sotrovimab with activity against the Omicron variant. Next slide, please. So let's talk about the current isolation strategy. This is the 4th time we're giving this webinar. This is the 4th different slide that I've had to use in the time we have been giving it. It is very much a moving target. The current isolation strategies in Ontario, taken from the current Toronto Public Health website, tell us that the patient himself, if they are fully vaccinated or a child under the age of 12 years, need to self-isolate for 5 days from symptom onset or positive test date, whichever occurred first. Those, however, who are not fully vaccinated and over the age of 12 or are immunocompromised or have been hospitalized in a non-ICU setting or are in a long-term care setting, these individuals need to self-isolate for 10 days from symptom onset or positive test, whichever came first. And those with severe illness requiring ICU care require 20 days of isolation. That's for the patient. Now, what about the household contacts? Well, that has loosened up very considerably. Self-isolation for household contacts is still required to be as long as the case itself, unless they are asymptomatic and have any one of the following criteria: a prior positive test within 90 days, presumably they will have ongoing immunity. They are over the age of 18 and had 3 vaccine doses, or 4 if they are immunocompromised, or they are under the age of 18 and have had 2 doses. These individuals do not require self-isolation. Now, if the individual is immunocompromised and does not fit into any of those criteria, then 10 days of self-isolation for those individuals is still required. What about asymptomatic contacts? First of all, who are they? Asymptomatic contacts are individuals who have been in direct contact with the infected individual at a distance of less than 6 feet for a 15-minute period at least without masking. Now, these individuals, again, do not require self-isolation unless they are symptomatic, in which case they may well be a probable case and need to follow the patient isolation strategy. But they do need to monitor. It is recommended now in this day of optional masks that they do wear masks, and they avoid high-risk settings such as long-term care facilities, healthcare settings, and of course contact with vulnerable individuals. Next slide, please. Well, here is the latest Ontario science table recommendation for how we manage these patients. And they, first of all, require a determination of their risk. And they have simplified this into simply two risk categories: those with standard risk, who are considered to have a risk of hospitalization of less than 5%, as well as those at higher risk, who are defined as having a risk of hospitalization of greater than 5%. And you can see, in order to stratify those, we base it on parameters of age, vaccine doses, which is mitigated through risk factors, and also whether or not they are immunocompromised or pregnant. So for example, you can see on this table that an individual who is age 40 to 69 has had 1 or 2 doses of vaccine. We then want to go and take a look at the risk factors on the right side to determine whether or not they are at higher risk. You'll notice, importantly, immunocompromised individuals of any age and regardless of other risk factors are all considered to be at elevated risk, and they are indicated for active therapy. Next slide, please. So here are the treatments, and Dominic is going to follow my presentation with a little bit more detail on this. And I will point out that individuals who are over that 5% threshold, it is recommended that they receive specific antiviral therapy with either nirmatrelvir, ritonavir, Paxlovid. But it should be pointed out that these individuals need to start their therapy within 5 days of symptom onset, which is different from the other two therapies, the monoclonal antibodies, sotrovimab, or the antiviral remdesivir, in which case you can start therapy within 7 days. It should be pointed out that if they are going to go on, I'm going to say Paxlovid, that the dose is 300 milligrams, or 2 of the nirmatrelvir tablets plus 1 of the ritonavir 100 milligram tablets. However, if they have renal compromise with an EGFR between 30 and 60, the dose of nirmatrelvir is reduced to 150 milligrams, or 1 single tablet in combination with 1 tablet of ritonavir. It's important also to realize that the ritonavir is in there not as an antiviral agent, but as an agent to inhibit CYP3A4, to prolong the effect of the nirmatrelvir. And of course, if it's going to inhibit 3A4, then it's going to inhibit all the other drugs that are metabolized through 3A4, and that needs to be taken into consideration. You know, for example, direct-acting oral anticoagulants, rivaroxaban and apixaban, both depend on 3A4 for metabolism, and their product monograph does indicate that they are contraindicated with the use of strong inhibitors such as ritonavir. Sotrovimab and remdesivir are also options, and the choice of which of these 3 drugs that is used is going to depend upon the ease of administration, the availability, contraindications, and other factors, but they do not specifically recommend one therapy, as far as I can tell, over the other at this time. If these drugs are not available, fluvoxamine, given as 100 milligrams twice a day for 15 days, or budesonide, 800 micrograms inhaled twice daily for 14 days may also be considered, but are definitely second-line therapies. Individuals who are at standard risk, however, these are considerations. Most individuals at standard risk can do with simply reassurance and monitoring of symptoms, preferably with oxygen saturation. However, in individuals who you think may be at risk but don't quite fit into that 5% category, the use of fluvoxamine at the dose we just discussed, 50 milligrams titrated up to 100 twice a day for 15 days, may be considered, as may budesonide, 800 micrograms twice daily for 14 days. Next slide, please. Currently recommended against are drugs that have shown no value or may be associated with more harm than benefit, such as antibiotics, monoclonal antibodies without activity against Omicron, hydroxychloroquine or chloroquine, ivermectin, and lopinavir, ritonavir, which are not going to provide any benefit and certainly can present potential harm. There are a couple of other therapies that are kind of on the borderline, not currently recommended, but do have evidence to support them, such as colchicine and interferon. Next slide, please. So the patient needs to be advised with regard to monitoring of any red flag symptoms, specifically what I like to say trouble breathing. A lot of my patients would not understand shortness of breath. Persistent vomiting and diarrhea, which potentially could lead to dehydration. Red flags for that, of course, are inability to take fluids, syncope, reduced urine output. I like to provide a home pulse oximeter if I can to the patients that I'm a little worried about. I fortunately have a bunch of those in my office that were provided to me through the Ontario government. And any persistent drop, they should be informed of below 92%. Oxygen saturation should trigger an ER visit and will often trigger admission. We don't usually require any further investigations in these patients, and I like to follow them up after about 1 week. Next, please. I want to spend just a couple seconds talking about budesonide and the principal study. This was a study that looked at 800 micrograms of budesonide twice a day against standard of care and some other therapies in individuals who were over 65 or over 50 with significant comorbidities. They could be unwell for up to 2 weeks prior to entering the trial. Next slide, please. 4,700 people were randomized to one of the 3 treatments, either budesonide, standard of care, or a few other treatments that are not adequately described in the paper. And the outcome showed that the primary outcome of time to first reported recovery is actually reduced by about 3 days in these individuals. And importantly, there was a 2% absolute risk reduction in hospitalization or death at 28 days. I will, however, point out that this did not quite reach statistical significance, but they did a calculation of the probability of superiority for this treatment, and it was 96.3% probable that it was, in fact, superior to placebo. Next slide, please. I will point out that for a while there was a bit of a shortage of inhaled budesonide. And there is evidence for other inhaled steroids, specifically ciclesinide at a dose of 320 micrograms twice a day for 30 days, which interestingly was quite the sort of the opposite. It did not show any reduction in duration of illness, but showed a very strong reduction, although it was a relatively small trial, about 200 patients per arm. It did show a 82% reduction in the risk of hospital admission or emergency visits, and that was statistically significant. So in the absence of budesonide, if you want to treat a patient, ciclesinide is probably an option, although not specifically recommended by the Ontario Science Table. Next slide, please. So how was Charlie managed? His family was first of all educated, as well as himself, regarding those red flag symptoms that I think we're all quite familiar with. He was instructed to isolate for 5 days. He was provided with a home pulse oximeter and told to make sure that he doesn't drop below any persistent drop below 92. And although he did not fit the criteria for the elevated risk, I thought that his obesity, as well as his smoking history, as well as his other comorbidities and his age being, 67, not so far from 70, that I thought it was appropriate to treat him and gave him 800 micrograms of budesonide to be inhaled twice daily for 14 days. Next slide. So that's the sort of top level view of what it's like in the trenches. To go to do a bit of a deeper dive, I will turn it over to my infectious diseases colleague, Dr. Dominic Mertz. Dominic?